Hello everyone, thank you for joining in. My name is Harsh. I'm a third year medical student at Charles University and one of the educational officers at UIMS. Welcome to the eighth lecture in the radiology series where we'll start with ultrasound. Today we have with us Dr. Teju who will explain the basic principles and fundamentals of ultrasound. Before we begin with the lecture, please feel free to type in your questions, queries, and doubts in the chat, and we'll get to them as soon as possible. Over to you, Dr. Tiju, and enjoy the lecture, everyone.
Thank you so much. Welcome everyone to another presentation in the Introduction to Radiology series. Let me just share my screen. If there is any problem in seeing my screen, please do tell me.
It's all good.
Okay. So, as I always say, our aim with these presentations are basically to help you introduce with all these imaging modalities, develop the familiarity with these imaging modalities, increase your confidence in using these imaging modalities, reading these images, and thereby improve your clinical practice. So today we are going to be looking at ultrasound imaging, and specifically I have divided it into two parts. Part one will be today, which basically, as was told before, will be introduction and biophysics. And the second part will focus more on point of care ultrasound, which I feel will be the most useful part of ultrasound for any medical student or a clinician that is starting his or her practice. So point of care ultrasound will involve most of the things that ultrasound can provide us, and will help you understand what ultrasound is. So let's start with today's topic, that is introduction to ultrasound. Objectives will be to explain the basic principles of ultrasound imaging, identifying the key controls which is common to all ultrasound machines, and explaining how these controls can be used to create an optimal diagnostic image, and also to have some familiarity towards these ultrasound images so that they don't feel that alien to you. So let's start with what sound is. Sound obviously is the energy that is produced by a vibrating surface and that is transmitted through a medium. And specifically for our imaging, we use ultrasound. So what is ultrasound? Ultrasound has a frequency that is way higher than the audible range. Typically between 1 and 15 megahertz is what we use for imaging. And what are the fundamental parts of an ultrasound machine? So the image here shows that the fundamental parts are basically a transducer. You have a computer with a control panel and the monitor. So what's happening is within the transducer, we have an array of piezoelectric crystals. These piezoelectric crystals, when we introduce electric current to these piezoelectric crystals, they vibrate, hence producing ultrasounds, which are sent into the body. They get reflected from a tissue surface, which is being brought back to the transducer. And now the transducer acts as a receptor, receiving these signals, taking them back to the computer. And the computer processes these signals into a readable two-dimensional image on the monitor. Now, so this is the same thing in the slide. Next thing is, and I'll just show you the transducer. Within the transducer, you can see this is where the piezoelectric crystals are housed. And what is the principle of ultrasound? When you look at it a bit deep, it's called as a pulse echo principle. Basically, we already mentioned that the piezoelectric crystals are sending out ultrasound signals, and these ultrasound signals are sent as pulses. So maybe 1% of time it will be sending out a pulse, and the remaining 99% of time the transducer is acting as a receiver, listening in for those echoes. And basically, the principle is the distance of the reflecting surface can be calculated if you know the time that took for the sound to go to the reflecting surface and come back, and also if you know the speed of the sound. So you can see here, this is a transducer. We have the signal that is going, hitting the reflecting surface and coming back. So if you know this time lapse, you can calculate where in the image that particular surface is, and the computer uses this information that is received from the transducer. Now, each of these crystals, each of these points are receiving an echo that is sent out. And each of these points will act as a bright dot on the ultrasound image. And at the end, you get this nice 2D image on the monitor. Now, what you need to understand while you look at the image and you try to get to a diagnosis from that image is that sound, like light, has all these properties of reflection, scattering, deflection. And if you don't understand the basic biophysics involved in ultrasound image creation, while you read the image, you are prone to make errors or misinterpretation of this image. So what are these conclusions based on? We look at the spatial definition of the tissue boundaries, the relative tissue reflectivity, the echo texture that is within the organ, and the effect of tissue on transmission of sound. I'm going to go into details of each of these points in the following slides. So first thing, I told you that we have the transducer that is sending the signals down, and when there is a structure it collides with, it is reflected back and the transducer picks it up again. Now, here, whenever the sound is hitting a reflective surface at 90 degrees, there is like maximum reflection back and received by the transducer. So this helps us to get the best image. And this sort of reflection is called as specular reflection. And why does this happen? Why is it reflecting? It is reflecting because of the relative differences in densities across this surface of reflection. So basically, the term used is called acoustic impedance. It is very similar to, when we were discussing X-rays, we mentioned that the density of the tissue corresponds to the level of X-rays that is transmitted through them. That's the same way, the density difference will depend or determine how much of the sound is reflected, how much of it is transmitted through that surface, and how much of it is deflected away. And this information is very important while we think or look at the 2D images. Now, I told you that if it strikes at 90 degrees, it comes back. The maximum receiving is when the sound hits on the surface at 90 degrees. But what if it strikes at an angle? So in this case, this is a curved surface, and when the sound strikes at the curved surface, you can see that there might be some of it that is deflected back to the transducer, but then the others are deflected away. This effectively causes a certain problem while we are looking at images. For example, this ultrasound image is focusing on the abdomen aorta. You can see that the abdomen aorta is seen, but these two borders, the anterior and posterior borders, is well defined compared to the two lateral borders. And this is why it is important that when you're measuring the abdomen aorta, we use the anterior posterior diameter. Why? Because this helps us to accurately place the calipers. You can see this is the marking of the calipers at 4 points, but you can see on these two sides where we keep the calipers, the borders are not well defined. That means that if somebody else comes and tries to do the measurements again, they don't know where you have placed it. So reproducing these measurements becomes difficult when you look at the lateral borders. But if you look at the anterior posterior border, there's no doubt where you're going to keep the calipers and the measurements are accurate and easily reproducible. So always keep that in mind whenever you're scanning for abdominal aorta. Next thing I want to talk about is, we have said that there is a reflection happening when the surface, the ultrasound waves hit the surface, but not all of it is reflected back. Some of it passes through this surface and reaches the next. So imagine if you are looking at the liver. There are some ultrasound waves going into the liver, and there are different cells structures within the liver, and this ultrasound gets basically scattered across because of these cell structures, and then eventually comes back, and then the transducer picks them up. And because of this scattering, there is an increased brightness that corresponds to that organ. So you can see in this particular ultrasound abdomen, you can see the liver is being brightly lit compared to the surrounding tissues, and kidney is seen right beneath, and it is slightly darker when compared to the liver. So that differentiation happens because of this scattering of ultrasound within these tissues. And obviously that is the reason you get this grainy image within the organs as well. Now we can clearly differentiate these two organs, and that is because of the specific scattering pattern produced by these two organs, and that is what we call as the echo texture of that organ, that helps us to differentiate these two organs so well in the ultrasound. And now, before I go any further, I want to tell you that we have so far discussed that ultrasound is being sent out by the transducer. The echo is then picked up by the transducer, the pulse echo principle, right? Now, even though the echo is being picked up by the transducer, how we use this echo, that is how we analyze this echo and how it is represented in the image, will decide on what type of ultrasound you have or what mode of ultrasound you have. Classically, there can be A mode, B mode, and M mode. So what is A mode? A mode is not that commonly used, and it is more specific for eye ultrasounds. But in this particular mode or type of ultrasound, what they do is, the echoes coming back, and for each layer, there is an increased return of signals. And that layer is represented in a graph with the x-axis being the time and the y-axis being the amplitude. So if I'm doing an A mode ultrasound of the abdomen, say, and this is the image that corresponds to that, you can see that with each layer that I am transversing with the ultrasound, I get an echo back, and it is corresponding to each of those peaks on that graph. This is A mode in its simplest form. Now, how do they use it in eye? So this is what happens. So when you use the ultrasound probe, you can see that each of their layers are showing up a peak. This is an example of the A mode ultrasound in eye. And you can see the peak corresponding to the probe, the cornea, the anterior lens, the posterior lens, the retina, sclera. Now, one of the uses for A mode in eye is if you have to calculate the lens power that is required when you're replacing the lens in cataract surgery. So if you know the distance of the eyeball, you can basically calculate the power of the lens that you need. So that is one of the uses for A mode. B mode is the one that you have been seeing so far, the pictures that you saw so far, where each of the amplitude that we saw in the A mode is represented as a point of brightness. And this point, when you look at all of the piezoelectric crystals present in that transducer, each of them giving a bright point, you finally end up getting that two-dimensional image. Now, this is a two-dimensional image caused a B mode of the liver. You can see again the echo texture of the liver, so characteristically present there, and this is the reflection of the diaphragm that you can see. Okay, so whenever you are doing ultrasound, now this is not as easy when I'm explaining it with just pictures, but if you have chance while you're doing your clinical rotation, if you see an ultrasound machine after the class, go and look at it, go and look at the various keys there are, various transducers that we'll be discussing today. See how each of them are held, and depending on where you hold it, it will decide on how the image comes up. And you need to have that three-dimensional visualization within your head to understand this 2D image. So there is a limitation when I'm discussing those scans with you, but I'll try and make it as simplistic as possible. So next thing is something called as M mode. Now coming to M mode, so what we do, in B mode we are having all of these things, but say we are looking at the heart and the heart is moving. We can see in the B mode all the valves opening and closing, the muscles contracting, relaxing, but you are not sure if the mitral valve is completely closing or not, if the mitral leaflet is touching the left ventricular wall or not. So you want to confirm that, and that is where M mode or motion mode comes into play. So what you're looking for is, if you look here, this is the representation of B mode that you are looking at. And you can see that all we are looking at in M mode is this linear section. So we draw a line, that is when you set up the M mode in the ultrasound, it tells you which line you want and you can select this line. So when you select this line, only this linear segment is focused on, and then the ultrasound looks at that section for maybe 4 or 5 seconds and then gives you this particular image. Now, I know it looks quite confusing, but every layer that you saw the ultrasound traverse here can be seen here. So this is the top portion here, and this is the bottom portion here. And this is the ventricular walls that you see here. And then we have the mitral valve leaflet inside. So what you see here over time period is the movement of the mitral valves opening and closing. So you can see that it is touching the left ventricular wall here, and this way you can rule out a regurgitation. And also M mode is useful in calculating ejection fraction. But again, today we'll be focusing more on B mode, which is the most important point in point of care ultrasound. So next thing is, sorry, bear with me. Next thing is, I want to talk about the artifacts that you come across while doing an ultrasound scan. First and foremost thing I want to talk about is reverberation. Now, I told you that ultrasound, while going through different mediums, will come back as a reflection, which is picked up by the transducer. Now imagine when the ultrasound is going through a fluid-filled cavity like a cyst. What happens is the sound wave starts to bounce around in that space. And each cycle, a bit of the ultrasound goes back to the transducer. Now we have already learned that the distance of the reflecting surface is calculated as time into distance. So because the first one came back immediately, that will be the first layer that the machine thinks that the reflection happened from. But as the bouncing waves take more and more time to go back, the machine will think that there is a thicker layer just underneath the layer that they saw before, and it will end up in an artifact that looks like a comet's tail. Like when you see the comet going through the sky, you can see this dust particles trailing behind like a tail. And that will be the same way. If you look at this ultrasound of the liver and gallbladder here, what you end up seeing is these tail-like structures. These artifacts are as a result of adenomyomatosis of gallbladder, which causes these small fluid-filled sinuses within the walls of the gallbladder. So that is why you end up getting these kind of artifacts. So if you don't know that, you're going to end up thinking that is something else that you're visualizing there. Next thing is shadowing and enhancement. Now, shadowing we already discussed briefly when we were looking here. Because of the deflection, if you look here, because of the deflection, the sound has gone this way. Obviously, all of this sound is going to be reflected back to the transducer. And whatever went through the aorta is reflected back from here, which means that this portion has not received any sound. And as a result, you can see that it is darker compared to the other two structures, and this is a shadow. And the result is because of the deflection here. And what you see here is much more brighter compared to these two sides, and that is because the fluid within here gives, like, lets through more of the sound. It's like when a structure lets through a lot of radiation, the places behind that structure will be enhanced in the X-ray. The same way, the sound is easily sent through the fluid medium. That means that it becomes a bit more bright because it has received more sound, and hence more echoes have come back from that side. So I've made another picture here just to explain that again. So this is a fluid filled cavity, and here you can see the shadows on the side and the enhancement here. And this is kidney. Now what happens here is this is a smooth curved surface which also causes a deflection, and this is called as a critical angle shadowing. And in order to understand or visualize this particular area, we'll have to move the ultrasound around so that we overcome the shadow and see this border accurately. So that is why it is important to understand what you're seeing on the image so that you can adjust the probe placement and get a better image and get an altogether three-dimensional view of what you're looking at. Next thing I want to talk about is mirroring. Now, again, coming back to the basic principle, you have the ultrasound going from the transducer, hitting on a surface, reflecting back, picked up by the transducer. The distance is calculated as time multiplied by the speed. Now, imagine if there was a smooth surface which caused a deflection of sound, and it is not picked up by the transducer, it just gone some other way. It hits on another structure, comes back to this reflecting surface, gets reflected back to the transducer. So if you look at this image, it's a bit easier to understand rather than just listening to me just saying it. So this is the transducer. You have sound waves going down, hitting on this reflecting surface, and then reflected back to the transducer. But some of the sound got deflected and sent this way. It has come across another structure, got reflected back, hit this structure, and then reflected back to be picked up by the transducer. The same transducer has sent other ultrasound waves that are struck at that particular structure and then received back, which will be displayed on the image like this. But because this particular time gap happened, ultrasound machine is going to think that there is another structure way deeper than this particular reflecting surface, which will be shown as a mirror image. So you can see here a mirror image being formed on either side of the diaphragm. So this is the liver diaphragm, and this is, you can see that a bit of the liver is being mirrored on the other side of the diaphragm because of this particular phenomenon. Next thing is attenuation. Now, you know that radiation and X-ray, radiation passing through a structure gets absorbed. Just like that, sound also gets absorbed by tissues, reflected, deflected, scattered, and as a result, as sound goes farther and farther away from the transducer, the strength or the intensity comes down. And as a result, as it goes lower, farther and farther away, the strength comes down and you start seeing a less clearer image. Basically, the resolution goes away as the distance goes away. And you also have to understand this basic principle that the frequency of the ultrasound is directly proportional to attenuation. That means that if you send a high frequency sound wave inside, it gets attenuated very fast. So that means that the penetration will not be that much or will not be that deep in a high frequency wave. But in a low frequency wave, because the attenuation is less, it can go deeper into the tissue. Next, I want to talk about the transducers. So the basic things that we use to send the ultrasound into the tissue. There are different types of transducers, but in point of care ultrasound, we are going to be dealing with these three workhorses, basically the linear transducer, the curvilinear transducer, and the phased array. Now, from the image, it is very clear why they are called as linear and curvilinear. We'll come to phased array in the end. So in linear, because of the way the arrays are housed, they come up, the sound waves come out in the form of a rectangular sheet, or basically, and the same way the image is also seen in a rectangular fashion. This is a high frequency probe, means that the sound waves are usually released around 12 megahertz. And because of that, the depth will be very less. Maybe very good images are seen less than 5 centimeters, but it can go up to 10 centimeters of depth within the body. But it is very good for resolution in that small depth because of the way the images are sent, and because of the high frequency, the resolution will be very high, but it can't go much deep into the tissue. Next is the low frequency curvilinear probe. You can see that the sound waves are fanning out from the surface of the probe, which classically gets you this image, which is what we always visualize whenever we think about ultrasound. Now, this image is that of the kidney, and the advantage is this is a very low frequency probe, and this is the most commonly used probe, and the frequency is around I think 1 to 4 megahertz, and the distance it can go is a maximum depth of 30 centimeters with the low frequency curvilinear probe. And now coming to phased array probe. Phased array probe was the genius of people or clinicians or physicians wanting to see a live heart beating, basically. So in the late 70s, when the X-ray were there, people could see the outline of the heart, but it was very difficult to see the inside of a living person's heart. So when the ultrasound, the sonar and all those uses of ultrasound starts coming out, and people start deciding to use ultrasound in medicine, they're thinking, how can we use this to see inside the heart of a living person? Now, you could just say that I can use a low frequency curvilinear probe and just look in. The problem is, now, ultrasound cannot pass through air, and ultrasound is completely reflected by dense structures like bone. Now, where is heart situated? Heart is situated here with lungs full of air and protective covering of a rib cage. So if you use a big, wide probe like the curvilinear probe and place there, you have limited visualization because all you see is a shadowing of the bone. So how do we get across this? So the first important thing that we need is we need the size to be small, the footprint to be small enough to be between the ribs. Second thing, we need it to fan out as soon as it leaves the ribs. So it has to be smaller so that it can be between the ribs, and also the sound wave should be fanning out so that you can see a wide area within. So the first idea that they came across was, what if we take a crystal and then just fan it around inside that housing so that it causes this fanning out motion of ultrasound. The problem with this model was that it causes a lot of mechanical shaking within the transducer. So the next idea that they came across was, what if they cause this timed delay of ultrasounds coming out from all these crystals? So that effectively causes this fanning out of ultrasound because of this timed delay of emission. So that is the reason why we call it a phased array probe, that difference in time, basically. And it helps us to overcome the issues that we had earlier and helps us to visualize the heart. Okay. Coming to the various knobs within the ultrasound. Now, what I've put up here is a picture of one of the older generation ultrasounds. You can see a lot of knobs, buttons, and sliders on there, and you can see something like the undersurface of an old mouse, a tracker ball. So this tracker ball effectively worked as a mouse, where we can move the cursor within to all the calipers in the image to basically measure and everything. But then we had like a touchpad kind of setup for instead of the tracker ball. But now these days we have a touch screen control panel where we effectively touch and select all the controls that we need. So what are the most important controls which are common to all ultrasounds machines, and how do we use them to improve the image quality that we are receiving from the structure that we're looking at? One second. So this is how a control panel will look while you are about to scan. Before you reach here, you have to select. You can see that you have to select which probe you want from the 3 probe selections that you have. Also, there are other probes, as I said, but these are the most common. So you select the probe, and also you select the site that you want to visualize. Now you have to also see that there is this small ridge that you can see on the sides of these probe, only on one side, see? And that effectively helps you to align with the image. So you can see on here, this part corresponds to that ridge. So whenever you hold the probe, that ridge should correspond to this image, the side of that image. Otherwise, you're going to have a wrong orientation of the image. Now, once you select the probe, once you select which site you want to examine, this is what you're going to end up having. And this control screen gives you this particular option. Now, this is called as the gain. Gain basically means you are going to change the strength of the signal, returning signal, and thereby you are adjusting the brightness. Imagine in a TV, you are adjusting the brightness. So if you adjust the brightness to too bright, to this extreme, you're going to end up losing your resolution. You're going to have this brightly lit image and nothing is visualized. See, the difference between kidney and liver is so poor here that you can't properly distinguish the structures. Or if you go and make the brightness too dark into this part of the grayscale, you're going to end up getting a very dark image, and practically the image is lost. You can't really make out anything here. So it is important that you set this slider to the appropriate gain that will help you visualize whatever structure you're looking at in the most clear way possible. Now, there is another concept here that I want to introduce called as time gain compensation. Now, if anybody can tell me what attenuation is, that will be really great, so I know that you're all not sleeping. Or if you can tell me what is the reason for attenuation, or anything about attenuation, that would be really great. If I just stop sharing. Nobody? So I'll just repeat what attenuation is. Attenuation is the loss of strength of amplitude. Yes, reduction of the amplitude of a signal as it goes through the tissue. Very good, absolutely right. It's like in CT, yes, absolutely. Let's go back. And the reason is I want you to understand attenuation before we can go to the next part. Now, we know that uh, as we go down the image, we are losing resolution because the sound is getting attenuated. Now, how can we get over that? Imagine if the machine selectively changes the amplitude of the returning signals based on the depth, so that everywhere we get the same resolution or same brightness for similar structures. That is basically time gain compensation. So the the end result that we want is, if we are looking at a vessel which is at 3 centimeters or at 10 centimeters, both of them should appear similar. A vessel at 3 centimeters should not look different to a vessel at 10 centimeters and making you confused as to what this structure is. So time gain compensation can be preset by the machine as per the structure that you're looking at, or some of the machines will have sliders like this. So this is a slider. See, these sliders will effectively change the gain at varying depth of that particular tissue that you're looking at. So that is one way of changing it. These days, machines usually give us a near, far, and overall gain control. So the bottom one is the overall gain control, and this is the near, and this is the far gain control. Okay. So I hope you understand the importance of time gain compensation and the importance of gain. Now, these are the structure, these are the things, the keys that you'll be using a lot while you're scanning so that you get the appropriate image. Next is depth. Now, looking at this particular control panel, you can see all these lines on the side. This corresponds to the depth, usually in centimeters. You can see that it is currently set at 3.5 centimeters, but you can change it according to which structure you're looking at. Always start your image with the adequate depth so that all of the organs of interest are seen, and then afterwards you can adjust the depth so that you don't lose a lot of resolution in unwanted real estate here. So in this particular case, you can see that all of this is unnecessary and the machine is trying to compensate for gain in all of these areas. But if you change the depth just to look at this, the machine is able to increase the resolution of that particular section and you end up getting a right image. So here, this yellow basically corresponds to the depth that we set up at, and you are looking at the kidney within the abdomen. Now, next thing is Doppler. Doppler basically runs with the concept that an object that is moving towards you will sound increasingly louder, and an object that is going away from you will sound increasingly, or the loudness will reduce as it goes farther away. Now, inside our body, we have blood flow and we have RBCs within that blood. So what we are doing is we are sending the signals or the ultrasound waves towards these red blood cells and seeing if the red blood cells are coming towards you or if the red blood cells are going away from you. And then we arbitrarily assign colors to that so we can differentiate it. So the color code is blue away and red towards. So imagine like Bart, blue away, red towards. So in this particular ultrasound image, you can see blue will be the blood that is flowing towards the transducer. Red will be the blood flowing towards the transducer, and blue will be blood flowing away from the transducer. And this is one form of Doppler. This is a color Doppler. There is also acoustic Doppler, where you can hear sounds like where that will help you to understand if there is an arterial flow there, like to use sounds to recognize the arterial flow. And then there are numerical Dopplers, which will help us to give various measurements that will help to calculate various things. So there are different types of Dopplers. We have only looked at the most common or the most used Doppler, the color Doppler. And another concept, now I know that we have so far discussed where in linear transducer it's going straight, in the curvilinear it's being fanned out, the ultrasounds. But in reality, there is a point of convergence, and then it separates away. And that point of convergence of the ultrasound in front of the transducer is called as the point of focus. And the point of focus is the point where there is maximum temporal resolution. Now, you can set this particular arrow here basically sets the focus point. So as the depth of interest, or when you're starting to look deeper into the body, you should adjust this focus so that the resolution of that structure that you're looking at becomes better. We have already discussed about echo texture, which helps us to differentiate various organs. But structure within the organ, say you're looking at a similar in brightness compared to the surrounding structures, and you want to differentiate it. So if you put the focus point on there, the resolution becomes more clearer, helping you to differentiate that particular foreign body from the surrounding structures. Or say if you're looking at nerves or specific points within that organ and you need to have a better resolution, focus is going to help you. So what are the things that really affects the image quality? The image quality will be depending upon the axial resolution. So what is axial resolution? The ability to differentiate 2 points along the line of transmission of the ultrasound. And that is effectively dependent upon the frequency. I told you that higher frequency means higher resolution, but lesser depth because it attenuates faster. And lateral resolution basically means ability to differentiate 2 points that is side by side. And we have just discussed that is dependent on the focus point. One more thing that can affect the image quality is the thickness of the slice of the ultrasound. So you have seen the ultrasound probes here, and you can see the thickness of the ultrasound waves that is coming out, which will come back and then be picked up by the transducer. And that thickness, the slice thickness, will also affect the resolution. And this slice thickness is basically dependent upon the design of the transducer, the quality of the lens, and such. So these are the 3 things that will affect the quality of your image. Now, last, I want to talk about safety. I know that ultrasound is considered as the safest mode of imaging, and true, it is the safest mode of imaging. And I don't think there is any evidence of ultrasound causing any harm. But if you look at it theoretically, ultrasound can cause harm because anywhere you send in energy, it can cause changes. For example, you are sending in sound waves which are absorbed by these cells. Temperature of these cells goes up, there can be cell damage. So it is important that you keep that in mind. And in order to reduce harm, you should try and avoid, if you can, to prevent, basically avoid prolonged scanning of the same place of the patient, or repetitive scanning, or especially in fetuses, because they are more fragile, limit the scanning exposure in fetuses. Also, another way you can cause harm by ultrasound is you are using the same probe in multiple patients. So just like you're supposed to wash your hands, you're supposed to clean the probe. What do you clean the probe with? Alcohol-free gels. Why alcohol-free gels? If you put alcohol-based gels to clean the probe, it's going to start destroying the transparent protective layer on that surface, and slowly start destroying the probe itself. So also, one more thing I want to mention is in the case of ultrasound Doppler, there are contraindications. You should not be using it in fetuses that is less than 8 weeks. You should try to avoid using it for head, neck, or spinal scans in fetuses or neonates. And you should not use ultrasound Doppler in eyes. Why? Because it increases the local heat production in that particular area and can cause damage. With that, I'm going to stop the introduction part of ultrasound. I know there was a lot of physics, a lot of parts that I said. If there is any doubts that you have of any of these things that we discussed, please feel free to ask me now so that we can just go through them again. If not, I think we'll wind up today.